All right, so Joe, I know that all of us like to do more procedures, get more patients treated. What have you found to be effective in terms of giving a good talk for structural heart outreach?
Yeah, thanks, Rainey. So this is a really important topic. I think when you think about a structural heart program, there's really three domains that you have as a metric for how you're doing. The first is outcomes, and so we get better at outcomes by using a great procedural technique and having experience. There's access, which have metrics like referral to implant time and the workflow of your program. And then there's volume. And the best way to grow volume is to get out there, boots on the ground, and talk to your referring physicians. And in 10 years of doing this, I've come up with some good strategies that I think are successful in getting patients into the structural heart clinic and getting them on the procedure table in a timely manner. I'd like to give a shout out to Christian Spies. I borrowed some of these slides from him. But when you're talking to your referring physicians, I think the most important point you can take home and the best theme that you can have is referring patients early. You want to get patients referred early so you can catch them earlier in their disease progression, and they're going to have better outcomes with the procedure, and they're going to have better outcomes long term. So the most successful strategy that I found is this slide deck I'm about to show, which I think really helps referring physicians feel like they have a lot of power to get patients treated early and impact their outcomes overall. So I start by talking about the stages of valve disease as they're set out in the AHA, ACC guidelines, which put patients in an A, B, C, or D category based on their symptomatology and based on whether they're at risk or it's progressive. And this is good for screening, but it's not good to determine the timing or repair of repair or replacement. So what I like to do with referring physicians is really make it very simple and compare heart valve disease to cancer. And I think everyone has a good fundamental framework for how they think about cancer. And so I show these slides. You know, cancer progresses through a very set number of stages. It starts as carcinoma in situ, it becomes locally invasive, and then it becomes metastasized. And the earlier you can refer patients, the better their survival rate. And really, if you think about it, valvular heart disease is no different than cancer. The earlier you catch this valve disease, the earlier you treat it, the better the outcomes for the patients. And we actually have data to support this. So after I kind of make the analogy to cancer, I'll show them we know that the outcomes for severe inoperable AS are worse than almost every horrible solid tumor cancer. So this is a mortal disease, and unlike cancer, it's one that we actually have a cure for. And so once I kind of set the stage with valvular heart disease being similar to cancer and the outcomes for valvular heart disease being abysmal if it's untreated, then I show these slides. So this is the Philippe Genereux staging of aortic stenosis. It starts with simple, isolated, severe aortic stenosis where the heart hasn't been damaged at all. There hasn't been any impact on the ventricle or backflow into the right side. It progresses to left ventricular damage, manifest as lower ejection fraction, myocardial fibrosis. Then it reflects back into the left atrium. You start getting mitral regurgitation. You start getting AFib. You start getting left atrial enlargement. Then it goes back into the pulmonary vasculature and the PA pressures start going up. You start seeing tricuspid regurgitation. And then really the death rattle of end-stage severe aortic stenosis is when the right side starts to blow up. You get RV damage, RV dysfunction. And so we really want to catch patients early at this stage 0. There's in fact lots of clinical trials ongoing to look at the benefits of early intervention for aortic stenosis. And when you look at the partner data, it's clear that patients with stage 0 aortic stenosis have much better outcomes. And so by referring the patient early to the structural heart program, you're really saving them from having an untoward outcome and improving their longevity and reducing their mortality. So this is a really successful strategy that I found for bolstering your structural heart volume and getting patients in early. So, Rainey, what do you think about this? What is your approach to outreach?
Okay.
What do you think?
Well, first of all, I think I need to get better at outreach. I totally agree. I have so many of my patients I see now are just getting, presenting so late and they're just so sick. And, it would have been much better to treat them years early. But I think what I see with a lot of referrings is they talk to patients, say, how are you feeling? Do you have shortness of breath, chest pain? Patient says, no. They say, well, you're asymptomatic. We don't need to do anything. And I think, I mean, what do you do with that? How do you like educate that? There's a lot of new guidelines that, we should be potentially treating these asymptomatic patients.
Totally. No, I think that's a great point. So the other point I'll make when I show these slides is that one of the things we've learned from working so closely with our heart surgeons is asking those three fundamental questions that we all learn in medical school are helpful, but they're not the end all be all. So asking people if they've passed out, if they have chest pain, if they're short of breath, those are helpful. But what you really need to ask patients is there anything you were doing a couple years ago that you're not able to do
Yeah.
today? And so I try to educate primary care doctors on how to take a history in valvular heart disease because it's very nuanced. And moreover, you have to ask the spouse, what's going on with your
Oh,
husband? Are they the same
yeah.
person they were a couple years ago? And it's really remarkable how many symptoms you can elicit by asking the question that way. And then lastly, I'll always emphasize that if they're asymptomatic and they're severe, you have to put them in a treadmill because the
Yeah.
guidelines have now changed. That's a 2A recommendation. You got to get these patients on a treadmill if they're asymptomatic to prove that it's safe for them to walk around and engage in their daily activities.
Yeah, no, I agree. I think that's so true. And I think, there's just too many patients out there who are not getting treated. Um,
Yeah.
and you're referring to, you're talking about here, are these primary docs or what about other cardiologists? Because I find that most of my referrals come from other cardiologists.
Absolutely. No, I'm probably 75% cardiologist, 25% primary care. We've really tried to set it up whenever there's a new referral for valvular heart disease in our practice that they go straight to structural just to bypass that extra visit. And my partners are fine with that. But yeah, I think for both cardiologists and primary care doctors, this outreach talk works. And it's a very simple message. Valvular heart disease is cancer. Refer early so that your patients have a better outcome. And I think that really resonates with these docs.
Yeah, no, I totally agree. And then what about some of the other recommendations? I saw a patient this year. He had a mean gradient was a 50 something. Vmax was like 4.8. Um, we do have some guidelines just on the severity, um, surgical. But any thoughts on that?
Yeah, I mean, with critical AS, I don't like putting those patients on a treadmill. If their gradients are super high and their Vmax is more than 5, it's not hard to elicit symptoms from those folks. So I'll usually just do those folks. But all the other people, I really emphasize the treadmill. I think it's super helpful. And then I tell patients, this is going to make you feel better. You're going to have peace of mind that when you go to walk your dog up the hill or when you go take that hike with your grandkids, that you're not going to have sudden death. And so that's really helpful to get patients to want to do the treadmill so that they can know that either they need their TAVR or we can continue to follow them.
Got it. And I guess the other, question is, what do you look for on a treadmill? Are you comparing how far they went to norms, or, what are you doing?
That's a good point. I mean, I think so. The Mayo Clinic data suggests that if they have a very low functional capacity for their age and gender, defined as less than 60%, if they have significant ST depression, ventricular arrhythmias, or a drop in blood pressure, those are considered high risk findings, and those patients should undergo TAVR. So those are the criteria that I use on my treadmills, and I found it to be pretty helpful.
Yeah, no, Joe, I agree. And I think that having a good chart of functional capacity versus age, where they should be, I think that's really important.
Yep. Sounds good. Thanks, Rainey.